Hi, my name is Cassidy McGee, and I'm in charge of Domain 2 of Benner's Domains, which is the teaching-coaching relationship. To preface this, I just wanted to start out by saying throughout our career as student nurses, we've been drilled about the importance of patient education, and this presentation, our goal is to figure out how to do this effectively and why it's so important. So without further ado. The importance of the teaching coaching role is what I'd like to start this presentation by talking about. This is significant to nursing practice because we as nurses have the experience and knowledge about the hospital setting and new illnesses that are unfamiliar to the patient. We are so familiar that we may take for granted our education of the patient condition and assume that they will know what is going on in their bodies. Our role is important for a multitude of reasons. The primary reasons are patient care and patient safety. A patient may mistake improvement for deterioration and vice versa. So it's really important to know, for the patient to know what changes to expect and watch out for, because that lets the patient and us as nurses know when to step in and continue on with care, or if we need to change something up. Additionally, doctors may appear too busy to answer patient concerns, so that leaves nurses with the duty of answering most of the questions regarding their condition. Dr. Benner quotes, "Nurses take what is foreign and fearful to the patient and make it familiar and thus less frightening." Benner goes on to point out that in extreme situations, such as the hospital settings, there is a different skill set for effective teaching and learning strategies, which we will discuss in this presentation with her competencies. Benner lists 5 different competencies for teaching coaching techniques. The first is timing, capturing a patient's readiness to learn. The second is assisting patients to integrate implications of illness and recovery into their lifestyle. The third is eliciting and understanding the patient's interpretation of their illness. 4 is providing an interpretation of the patient's conditions and giving a rationale for the procedures. And the 5th competency is the coaching function, which is making culturally avoided aspects of illness approachable and understandable for our patients. The first competency is timing, capturing a patient's readiness to learn. Now, we've been a part of patient teaching since way back in 309, but as new nurses, we still may not always have a grasp on when to begin patient teaching at the perfect time. Benner states that an expert nurse may not even begin teaching or force information on a patient before they show an interest or commitment to learning. So what can that look like in the practical setting? This can be our patient asking questions about their condition, a new willingness to participate in care, or a change in behavior about their condition. I have a personal exemplar for this competency. Back in my 331 clinical, I had a patient with a new ostomy who was set for discharge home 2 days after I cared for her. At the beginning of the shift, I had my plan of care ready, which involved helping her change and clean the ostomy bag, as well as washing the stoma site during her bath. I was doing that at the beginning of the day per her request, and my patient said, "Does the site look bad?" And I said, no, it's healthy, it's pink, and I was like, and it's functioning properly, why is there anything hurting you? And she said, "No, I just haven't been able to bring myself to do anything with it yet, and I don't know how I'm going to take care of it at home, and I just don't know what to do." I told her that I can show her how to clean it and empty it if she'd like, and she agreed, so that's what I did. At the beginning of the shift, I walked her through taking the bag on and off, emptying it into the toilet, and cleaning the stoma area with a soapy washcloth. I really pushed this because I knew she would have to take care of this on her own eventually, and her expressing interest in her ostomy site let me know that she was ready to learn. The next competency is assisting patients to integrate implications of illness and recovery into their lifestyles. This is especially important and relates to our patients who have temporary or permanent disability. In these cases, the nurse should maximize the ability of the patient to continue meaningful life activities. This involves avoiding isolation and giving the patient and family alternate routes towards normal life despite physical limitations. Benner shared 2 strong exemplars for this competency, one of which I will share in this presentation, and the other begins on page 81 in our book. This exemplar involves a nurse helping a severely handicapped woman reestablish a meaningful life. This patient hadn't been outside of her room in 5 years and was dying of depression. She had right upper extremity paralysis and severe right lower extremity weakness after a stroke, and doctors said that exercise might kill her because her heart is bad. The nurse responded that this patient was dying anyway, and she's dying because her whole world is 4 walls. The doctors caved and ordered her PT, and the nurse got her out of her room and exercised her. The nurse didn't know anything about PT specifically for post-stroke patients, so she got a book and read up and learned how to do so. Eventually, the nurse got the patient to a point where she could walk with assistance, and the first day that patient walked out of her room, she burst into tears. 5 years later, she passed while cooking dinner. In the meantime, she had taught herself how to peel potatoes with one hand by wedging them against her paralyzed arm. Before this nurse stepped in, this patient was dying because she was being treated like an invalid, and she had felt useless and hopeless. By bringing motility back, she brought this patient's life back, which is a perfect exemplar of this competency. The next competency is eliciting and understanding the patient's interpretation of their illness. At this point, it's really important to not argue with the patient interpretation of their illness at this stage, but to instead acknowledge the emotional pain that is being shared. Benner went on to state that it's not relevant to change the patient's feelings prior to beginning teaching on how to care for that situation. A patient doesn't need to accept the new changes with their body or feel comfortable with them for teaching to begin. And also, it is important to work from the perspective of the patient to accomplish goals. My exemplar for this example is going back to my new ostomy patient that I used in my first exemplar. She stated at the beginning of her day and throughout the day that her ostomy site was disgusting, smelly, dirty, and it made her sick to her stomach to think about. And that was the reason why she had avoiding looking at it for so long, because she didn't want it to be a part of her body, and she kept referring to the site, the bag, and the stoma as it instead of being part of herself. After reading Benner's exemplar in the book with a similar patient experience, it brought me back to how I responded to this patient. I remember telling her it must be hard to have a new part of your body that you weren't expecting, but I think it would be beneficial to learn how to take care of it now, where I can help you, instead of waiting while you're at home alone to try to figure things out. I, along with Benner, didn't try to change our respective patients' minds. We just gave the information the patient needed to take care of themselves in the interim. The patient, by the end of the day, had looked and cleaned her ostomy site and emptied the bag by herself under my instruction for the first time. And I think me being there and being neutral about the site itself aided to her learning. I didn't try to change her mind about the site, and that aided to her being open to discussing and working with it instead of getting defensive about it. The next competency is providing an interpretation of the patient's condition and giving a rationale for procedures. This entire competency is based off of patient autonomy and the fact that patients have a right to know what is being done to them and why. Patients themselves will track their own condition or progress with or without the explanation from a nurse. And so by providing education about the expected progression through their illness, the patient will know what to expect and or report to the nurse. So this really aids in patient care and patient safety. But nurses also need to assess how much information a patient wants and needs, and explain that information in a way the patient understands. Common ways of doing this are by not presenting information with vocabulary above 8th grade reading level, and also making sure that if a patient does not speak English or your preferred language, you are getting them an interpreter to really provide that good patient teaching. The exemplar from Benner involves a neurosurgery patient in the ICU. This patient had just finished talking with her neurologist and vascular surgeons about a brain operation to relieve pressure around her ocular nerves to prevent her from going blind. After the doctors left her room, the patient asked the nurse, "Should I have this surgery? Is it going to be safe?" The nurse replied that the patient wouldn't be able to find any finer surgeons, but that she couldn't make that decision for the patient. The patient then expressed concern for a while that the surgery would prevent her from going blind, but could possibly kill her if there were any complications. The nurse stayed silent through the patient's talking and let her verbalize her feelings until the nurse offered to explain what the surgery would entail specifically. The patient agreed, and the nurse demonstrated the entire procedure on a head, skull, brain model and answered the patient questions as they arise as she was explaining the surgery and the different vasculature and anatomy of the brain. After all the patient's questions were answered, the patient did elect to have the surgery. But what's important is the patient made the decision on her own after the nurse gave her unbiased factual information about what the surgery entails and what to expect after the surgery. Our last competency is the coaching function, or making culturally avoided aspects of illness approachable and understandable. Some of these topics that are culturally avoided are illness, pain, disfigurement, death, and even birth, especially with our older or younger patients who are having birth. The nurse should offer education and understanding to increase patient control and acceptance. And experience, along with formal education, is needed to develop this competency because us as nurses have a very specific, unique relationship with these topics that other people don't explore unless they are experiencing it themselves. It is impossible to learn ways of being and coping with these topics by precept alone, and a deep understanding of the situation is needed. And it's not uncommon for ways of coping and being to be transmitted by demonstration, attitude, and reaction instead of words. So as new nurses, we should be getting out there and observing our exemplar nurses and our expert nurses to see the best ways of dealing with this. The exemplar that the Benner suggested was when a nurse had an encounter with a man her own age who was visiting his dying father. The father's condition had deteriorated rapidly, and the family was extremely distraught. The son went to the nurse in the hallway and asked how long his father had. And the nurse responded that these things are variable and you can never exactly know, so it could be hours, days, or weeks. The son then asked if there were any others dying on the unit, and the nurse responded yes. The nurse reported that the son then paused and asked a barrage of very blunt questions, like, how can you work here? How can you sleep at night? And how can you do what you do? The nurse reported being thrown off by the questions because she's never really been asked these before, especially by a patient. She answered with her feelings and philosophy about life and dying and nursing, how it was difficult and emotionally draining and sometimes hard to sleep at night, but also the gratification in helping a patient through the passage of death and helping the family through the pain of that passage gives her a gratification to keep going. The nurse said that the thing keeping her here is knowing that she made this rocky path smoother for those who travel it. And after that, the son hugged her and thanked her. The nurse broadened this man's perspective and acceptance. This is the coaching function, opening ways of coping that nurses have come to terms with that are largely avoided or unexplored by the general population. To conclude this discussion, I wanted to touch on how this competency applies to more than just the nursing role. Physical therapy, occupational therapy, speech, nutrition, and psych are all going to be consults that are involved in our patient's care. And the patient might have questions from a consult or about a consult that you don't have a great answer for, or that you're just not the best person to give the teaching. For example, if a patient is asking when he can move from a wheelchair to a cane, you can give an estimation from previous experience that you have if you have it, but ultimately physical therapy would be a better option to explain what's involved in getting the patient to that point. So we, as nurses, have to communicate the patient's questions to the right people in order for them to get the education they need at the right time. To tie up the teachings from this section, this quote from Benner explains the purpose of the competencies in the teaching coaching role for patients. Nurses, in the way they practice, in the way they approach a wound, in the way they talk about recovery from surgery, offer ways of understanding. The patient can come to a sense that the problem is approachable and manageable. We need to keep practicing with these competencies in mind because the hospital has variable situations that formal planned teaching learning strategies will not be enough to effectively deliver information to our patients. In teaching coaching role, expert nurses do not just offer information. They offer ways of being, ways of coping, and new possibilities for patients by means of perspective and nursing practice through these 5 competencies. Thank you for your time.